Hi, this is Unit 3 recap, and here we're going to be looking at IV therapy, blood administration, TPN. You will have 5 questions on this in this area in your exam. Infection control, total of 5 questions, and then inflammation and skin disorders for 8 questions. So we'll go ahead and start with the IV therapy. Be sure that you do review. You can actually go into your Canvas course shell for your lab, for your 242 lab, and access the IV therapy PowerPoint that's in there for you to review the material. Okay, but make sure that you look at the purpose, site selection, catheter selection, and then monitoring IV site. We need to, before we start IV therapy, you need to know what's the purpose. Are they just going to be receiving fluids? Are they going to receive meds? Is it because they're going to receive some blood products in the future? What types of solutions are they going to get in medications? Are they going to be very irritating or not? Very concentrated, viscous, that type of information for you to decide about the site selection, the catheter selection. Site selection, we're going to take other things into consideration, such as are they right or left-handed? Have they had previous IVs? We want to start above proximal and not distal to the last IV site. Do they have any scars, any bruising, any burns? Do they have any condition that affects the circulation of that arm? So all those things we take into consideration. We always start with the most distant possible IV because we're going to work up on that arm. Okay. So far as the catheter selection is concerned, again, you're really going to look at the purpose and what size vein you're going to use, all right? Because we don't want the catheter is too small for the vein or certainly not too large for the vein, because then it will lead to phlebitis. And so we look at the purpose and location to determine the size of the vein. The most common size, as you know, is the 20 gauge catheter. But depending on what the purpose of the infusion is, if it's for blood, then we want to get an 18 gauge, but we could give blood with a 20 gauge if needed. And then if it's just going to be a plain solution, like an isotonic solution such as saline, we might just go ahead and go with a 22 gauge. Okay. Monitoring IV site, you want to look at the IV site not only for complications, but to make sure that everything is well, that the dressing, the Tegaderm dressing is intact, there's no leaking, we don't want any moisture under there, no redness around the site, make sure that everything is intact there. So when you go to the next slide there about nursing care related to intravenous therapy, then, as you know, you need to check the doctor's order. Okay, now, once you have an order for an IV, you do not have to notify the doctor if it needs to be restarted, okay? You do need to notify them if there's any problem with the IV, such as local or systemic complications, or any complication, actually. So we're going to make sure that you have the correct infusion solution and rate. Make sure that you inspect and palpate the site, all right? We want to, the veins should be spongy, they should bounce back, and shouldn't be hard, they shouldn't roll, anything like that. If you're going to lock the IV, it says here really you should inspect it every 2 hours. If you have an IV going, if you have fluids, continuous fluids going, you really should inspect the IV site every hour. We're going to assess for respiratory status. We're going to monitor and make sure that we do not overload the patient. So of course the monitoring vital signs is called for to see if there's any increase in blood pressure or pulse. Intakes and outputs, especially 24-hour balance between the intake and output. Daily weights may be indicated, especially in your renal and cardiac patients. And of course monitor for local and systemic complications of the IV therapy. Systemic complications would be such things as chills, fever, any drug reactions from the medications or the fluids they are receiving. Local complications would be for phlebitis, infiltration, and infection. So we need to make sure that we're monitoring for that. Okay, moving on to blood administration then, on transfusion reactions. I thought this little clip art would be helpful for y'all. And make sure that you do study the different types, signs and symptoms of transfusion reactions. As you know, usually the transfusion reactions are going to occur within the first 15 minutes, or what we say the first 50 mLs of blood being infused. So that calls for us to remain with the patient for those first 15 minutes. Okay, anytime that we get ready to give blood, of course we need to verify the order, make sure that we have the appropriate MD order. Before we send for the blood, the unit of blood and stuff, we need to make sure that our patient is ready for the infusion. And that is because we have 30-minute leeway to hang up the blood from the time that it is picked up from the blood bank and then the infusion is started. That's a 30-minute window that we have. In total, we have 4 hours to infuse the blood. So you need to make sure, don't wait till the very last minute to go ahead and make sure that you have a patent IV. You need to make sure that you verify that you have a patent IV, that it's going to be dedicated to the blood transfusion or infusion. And that, of course, preferably an 18 gauge catheter for that. If you do not have a site, then you need to start an IV, because you do not want to be running anything else in that IV line. It really should be dedicated to the blood transfusion. Alright, so you check the order and you send somebody, doesn't have to be a nurse, going down to pick up the blood from the blood bank. At the blood bank, they do the checks on the documentation against the unit, things like what's the blood type, patient name, identification, make sure everything is correct, expiration date on the blood, things of that nature, and the blood then is brought to the floor. When you hang it up, it needs to be verified. Again, all documentation, make sure we have the correct unit for the correct patient. That needs to be done at the bedside by 2 licensed nurses, one of whom needs to be an RN. The RN is the one that's going to administer the blood. So you check all of those things again, do your patient identification, check all the blood unit information to include expiration date. Before the blood is hung up, we need to go ahead and do vital signs, baseline vital signs, so that we can then go ahead and monitor them throughout the transfusion. So we do the vital signs, start the blood. Like I said, nothing else runs with the blood, except the only thing would be saline. And then 15 minutes into the transfusion, we repeat the vital signs and compare them against the baseline vitals. Make sure that you do teach the patient as to what signs and symptoms or complications to be on the alert for, and to call you right away if it does happen. Things like they start having chills, or they start feeling that they have palpitations, or they start breathing rapidly, or have difficulty breathing, or complain of, have a headache, or start breaking out in hives, or facial flushing, or they start wheezing, any problems with breathing, that they go ahead and contact the nurse, get the nurse to the bedside right away. Of course, before you start the transfusion, you need to make sure that you do have consent forms signed, properly filled out and signed by the patient. Okay, then we're going to closely monitor the patient, and it's going to be vital signs every hour thereafter. Okay. One of the things, if a transfusion does occur, we need to stop the blood. That means the whole line, the unit of blood and the whole line is removed, and a brand new line with saline is hung up. And then, of course, notify the doctor, notify the blood bank, because there will be, if the doctor wants to order something to be given like Benadryl, or to see what orders he gives, when we notify the blood bank, they will send somebody to do some labs on the patient, renal panels and so forth. And then we will also need to collect the first voided specimen or a fresh specimen from the patient. Okay. Those hemolytic reactions down there on the bottom of the page, those ones can occur up to a week after the transfusion. And a lot of times what they do complain of is the low back pain, which indicates that it's kidney problems. Okay. All right. Make sure also that you review your different blood types, the O and the A and B. We know, of course, that the universal donor is an O negative, and the universal recipient then is an AB positive. Okay. Okay, we move on to TPN. You will have, that is also included in the test. And so I just have here as to the common TPN solutions. What I want you to take from this is that it's really a hyperosmolar solution. It's very concentrated and it's very high in dextrose, anywhere from 20 to 70%. Because it is so high in dextrose, it may cause glucose intolerance or electrolyte imbalances, because it does contain all its electrolytes, vitamins, insulin, heparin, it's amino acids, all of that in there, so we can have electrolyte imbalances or glucose intolerance. For that reason, we closely monitor that. As you know, a patient on TPN will have a daily complete chemistry panel done every morning, and then we're going to be monitoring bedside glucoses on them, and according to the hospital protocol, it's anywhere. Some hospitals call for every 4-hour blood sugars and other ones every 6 hours. So we're just going to follow the hospital policy, but it's going to be frequent monitoring of glucose. Alright, so some tidbits on when you have a patient that's receiving TPN. The TPN is mixed up or fixed on a daily basis in the pharmacy and sent up to be hung up. In the morning they do the battery of the blood panels, and then the physician will write the prescription for that day's TPN for the next 24 hours based on those results, and usually the pharmacy sends it up in the evening and we hang it up in the evening. So we are always going to use an infusion pump. If there are lipids in the TPN, it has to be through a central line. Cannot be a peripheral IV at all if it has lipids. We're going to, of course, closely monitor for circulatory overload. Remember that the fluid expands the intravascular compartment. We never ever try to catch up if it's running behind. If we have a TPN that runs out, we need to hang up a D10W while we're waiting for pharmacy to send us the next 24 hours TPN. And we need to hang up the new TPN that arrives with new tubing and filter. Alright, so every 24 hours is going to be a new bag of TPN along with new tubing and filter. We're never going to infuse any other solution or medication through the line. Of course, we need to use strict aseptic technique. Bacteria just love the solution because it's so high in glucose that it's perfect medium for bacteria multiplication. We're going to monitor the site. If it's a subclavian or a catheter that's inserted subclavian or jugular, monitor for subcutaneous infiltration. We can develop phlebitis just like with peripheral lines, and remember we have a very concentrated solution that's being infused. Monitor for catheter-related sepsis. We want to go ahead and monitor the site closely for any signs of infection, and of course record intake and output. Not only record intake and output accurately, but do daily weights, and of course we're going to be monitoring the daily labs and reporting them to the physician as soon as we get them in. Okay, the other section here is types of central venous catheters. Make sure that you do review. You do have that PowerPoint in your Canvas course for your lab. In your modules there on the different types of central venous catheters. The non-tunnel ones are the ones that we frequently see, like the subclavian and the jugular ones, and of course they're for a very short period of time that we have them in place. And then we have tunnel catheters, which are tunneled, but they still have the port that is outside the skin, so it still is a great risk for infection with those ones. And a common one is the Hickman catheter. We have the PIC, the PICU lines, not PICU, but the PIC lines, which you all are very familiar with. They're used frequently in nursing homes. It is longer term than the non-tunnel catheters and less chance for infection than those non-tunnel catheters, the subclavians and jugulars. You see them quite often. And then we have the implanted ports, which are probably the best ones. They are for long term. There's no exposure whatsoever because it's implanted, it's under the skin, so you have nothing sticking out. The risk for infection is minimal, and the patient can continue with their activities of daily living, no restrictions whatsoever, because it's not on the outside. There's no dressing changes that are needed or anything like that. Okay. One thing is that for the implanted port, we have to access it with a specialized needle, the Huber needle, which is bent at a 90-degree angle. Okay, infection control is the next section here. Make sure that you review standard precautions. Remember, we use standard precautions always. They are used for every single patient that we care for. And of course, standard precaution calls for our hand hygiene. We can use soap and water, or we can use alcohol-based sanitizers, hand sanitizers, except with C. diff. With C. diff, it has to be soap and water. Remember that gloves do not replace the need to wash your hands, all right? And we wash our hands before and after each patient contact. I have here bloodborne precautions. Bloodborne precautions are the same as standard precautions. That's what we mean. You know that with bloodborne precautions, anytime you're going to access blood, you need to wear your gloves. If you expect to have some splatter, then you need to wear your gown, okay? And then, of course, we have transmission-based precautions. I went ahead and pulled out this little table from your syllabus, which is a very nice and simple recap of transmission-based precautions. We have airborne, and of course, one of the most famous airborne precautions is the TB, but we also have varicella or chickenpox or disseminated herpes zoster or shingles. So with, you can review here. Remember that with airborne precautions, we do need to have a negative pressure room, and the N95, a special respirator, particulate respirator, is used by healthcare providers. Visitors do not don them because they have to be fit tested, and we don't go around fit testing everybody, and not everybody is qualified to conduct the fit testing, okay? Now, do we need to have gowns and gloves for airborne? No, we do need to have that respirator, all right? Meticulous hand washing is what is needed. And then, of course, you're going to use your standard precautions. So if you expect splatter and stuff like that, then, just like you make those decisions with standard precautions, you'll make those decisions for the gowns and gloves. Droplet, it's in that mucus, big droplet, and so it doesn't become aerolized like the airborne does, and so it just has a very small travel distance of 3 feet. So we do need to wear, healthcare providers wear surgical masks, or actually that duct type, that fibrous mask, if we're going to be close to the patient. That means within 3 feet of the patient. Do we need a private room? Preferably yes. If we can't get a private room, then we cohort them with somebody that has an infection with same bacteria, same pathogen. Do we need gowns and gloves? No. Again, you make a decision. It would be using standard precautions if you determine that you're going to be encountering splatter. That you would decide whether to gown and glove. But for sure, the surgical mask is required within 3 feet. And then contact, of course, all of them, of course, require hand washing, right? But contact may require, again, a single room, a private room, but you can cohort them. And is a mask required for contact? No, but gowns and gloves are required. I put down there for airborne and droplet precautions. Remember that when the patients are transported outside the room, they are the ones that wear surgical masks, and that's we're using the principle of protecting the portal of exit. When we wear the mask, healthcare providers, we're protecting the portal of entry. Make sure that you review about patient education. What would you teach a person, the family and the patient that is going home, let's say with an MRSA infection, and that the family would need to practice contact precautions at home. Now, they don't go around gowning and stuff like that at home, so we usually say don't share linens, don't share towels, use separate sleeping quarters, if needed separate bathrooms, keep the wound covered, those types of things. And then very good hand washing technique. For droplet and airborne, we're going to really teach them, again, it would be the same thing about not sharing sleeping quarters, things of that nature, and then for the patient to wear surgical masks. For all of them, especially for droplet and airborne, we're going to tell them to limit the exposure to children. Okay, inflammation and tissue integrity. I just have here about inflammation, the inflammatory response. Acute inflammation, we know that chronic inflammation exists, and chronic inflammation, actually, one of the takeaways is that it really starts affecting the body negatively. It affects the immune system, it delays healing, things of that nature. But we're going to address acute inflammation here, which begins within seconds to minutes following an injury. The injury can be physical, or it can be bacterial or chemical. The damage, like it says on there, but it does activate the inflammatory response, and it could involve, and usually does involve, the immune response, okay, because the body actually imprints the invader, all right, for future responses. All right, so you have the 4 steps of the inflammatory response. First of all, we're going to have redness, where we have blood rushing to the wound, and then the heat as the body systems speed up. This is the invasion, or not the invasion, but the rushing of the phagocytes, the white blood cells, to attack the invaders. And then we have the swelling. Again, this is from the white blood cells that are crowding the wound to fight this bacteria. And then we have pain that results from the swelling. That's the tissue response to an invasion. And remember, I did not write it here, but the response, how we treat inflammation, acute inflammation, is using RICE, right? Rest, ice, compression, and elevation. Okay, the inflammatory response to wounds, then, we have, again, 4 phases, and it's really wound healing. The first one is the vascular response, and this is where initially we have vasoconstriction, that's to stop the bleeding, reduce exposure to bacteria, and then we have the vasodilation to allow for the influx of WBCs, all right? And so here we have the engorged capillaries, and these produce, the vasodilation produces the redness and the temperature. Inflammation, of course, is the result of the influx of those WBCs to fight the invasion of pathogens or the injury. And then that's the initial one. Then we have proliferation, of what we call granulation. That can occur within the 4th to the 21st day after the injury. And this is where we have the new tissue growth. After that, we have the remodeling or maturation, which is really the scar tissue formation, which can take up to 2 years. And a scar is never going to retain the strength of the original tissue. It's going to have about 2/3 of the strength of the original tissue. So for that weakness, really, scars never are as strong. The tissue is never as strong as the original one. Pressure ulcers is the next one here. One thing before that I do want you to do is to go ahead and review the table on preventing pressure ulcers, which is on page 476. Has some very good information there on how to prevent them. I think that we are all very well versed, but make sure that you do review those actions in there, the best practices in pressure ulcer prevention. I have here the stages. I thought maybe this little graphic would be the best one as to stage 1, 2, and 3, and 4, and unstageable. We know stage 1 is just it's intact skin. There's no break in the skin. It's non-blanchable redness of a localized area. And it's very easy to get a stage 1, and it's very easy to reverse a stage 1. And then we have the stage 2, which is a partial thickness loss of the dermis, and that is usually presenting as a shiny or dry, shallow ulcer. A blister is a perfect example of a stage 2. Stage 3 then It's deeper and it involves the subcutaneous fat. All right, so it may be visible. It's a full thickness tissue loss. And then we move on to stage 4, which we're beyond the subcutaneous fat, and we may have exposed bone, tendon, or muscle. The unstageable ones, we say that they're unstageable because they're covered either with eschar or with slough, and we're not able to really stage it. So we can't see the true depth, and therefore we can't stage it. Wound healing is the next section on here. Just a few tidbits on wound healing. We know that to promote healing, we need to keep the wound moist. All right. The other thing is that we need to prevent injury to healing tissues. For example, if we're going to be irrigating the wound, we don't want to use direct pressure on the wound bed because that causes injury, and that will disrupt the granulation, the healing. So we want to prevent injury to healing tissues. Also protect the peri-wound, the skin surface surrounding the wound. We want that to be dry. We don't want moisture stuff because that promotes skin breakdown. So we want to protect the perimeter, the peri-wound skin. Dressings, there's a whole bunch of different types of dressings. Gauze still remains the most commonly used one. But there's a whole bunch of different ones depending on, there's hydrogel and so forth, but it depends on what we want to do with the wound. All right, we have we can fill the dead space, and we have some of those dressings that do that, or some wound fillants that do that, and then of course all of that promotes healing. We want to look if there's a wound infection. We're always going to be monitoring our wound for any signs and symptoms of infection. So make sure that you review that. Of course, there would be increased pain, increased redness, increased temperature around the wound, and maybe you have a new drainage, a yucky drainage, a foul odor. All of those are signs and symptoms of infection. We want to make sure that we remove necrotic tissue, because healing cannot take place if we have necrotic tissue, and plus necrotic tissue decomposes and promotes the development of an infection. We may irrigate infected wounds. Usually it's just saline. Remember, we don't want to use any other kind of unless we want to debride the wound, we don't want to use solutions like betadine or hydrogen peroxide. If we have developed a wound infection, remember that we do need to culture it before any antibiotic treatment is started. All right, so we culture before starting the antibiotic. And then make sure that you review the use of the wound vac. It is in vogue. We use wound vacs a lot. It creates a negative pressure, removes exudate or excess fluid from the wound so that it promotes the growth of healthy tissue. Okay, we're moving on. We're going to look at eczemas and then psoriasis. Eczemas, usually it's caused by allergens, okay? And so a lot of times people that have eczemas, like dermatitis and stuff, atopic dermatitis, also have allergies. So a lot of times we find that they have a lot of allergens. So what we need to do for people that do suffer from eczemas is to go ahead and remove the allergens, number one. We want to reduce the inflammation. We want to prevent infection, and we want to hydrate the skin. All right, so hydration, skin needs hydration. And so when you see people with eczemas, they have very dry, flaky, irritated skin. It's itchy. They have a lot of pruritus. And so they do a lot of scratching, and because it is so dry and it cracks, they're at great risk for infection. So the inflammation usually is reduced through the use of corticosteroids or steroids with them. Make sure that you review or keep in mind what are the signs and symptoms of allergic reactions, because you could have somebody that has, let's say, atopic dermatitis and may also be exhibiting signs and symptoms of an allergic reaction, such as wheezing or swelling of the throat or swelling of the face and so forth. Okay? Psoriasis is an autoimmune disorder, and it is familial. It is not an infection, it's not contagious, and the way that we manage it, what happens is that we have a rapid turnover of epidermal cells, and so it's a rapid growth, and that's why you have that reddening, scaly um, sores that are exhibited by psoriasis. So, or plaques, we call them plaque psoriasis, but there's a whole bunch of different types of psoriasis. But anyway, our aim will be to reduce the rate of that cell turnover, and so they are placed on steroids. Also, we need to monitor for complications, such as infection. That would be a big complication, infection. Um, the other thing is that because it does alter, the same thing with eczema, depending on how severe the eczema is, body image, so uh, we need to address body image with patients that do have psoriasis or eczema. And I mean, it's difficult for them to be out in public because there will be reaction to them, especially if they have the plaque psoriasis and they have it around the neck or the hairline or even face and stuff. So we need to address that. So there may be complications that are physical. What I'm saying is, self-esteem type issues, isolation, things of that nature. Another mode of treatment for them actually is ultraviolet treatments, and this is actually the doctor will write a prescription for it, and it's not something that you just go ahead and go buy a tanning bed and you use your tanning bed at home, or you go to tanning salons. There are centers, and the doctor has to write a prescription as to the ultraviolet treatment. And one of the reasons is that we need to get vitamin D. That's another treatment for psoriasis, is the application. Actually, they have vitamin D ointments that are applied also. Okay, but it is an autoimmune disorder, and what we want to do is to slow down the turnover of the cells, the replication of the cells, and therefore take care of those plaque lesions. The next one on here is cancerous lesions. Make sure that you review characteristics of a cancerous lesion. It's the ABCD. A for asymmetrical. It's asymmetrical. The lesion will be. B, the border is irregular, and then we have variations of color. So that's the C. We have different colors in there. And then the diameter, it will be greater than 6 millimeters. So how do we prevent cancerous skin lesions? Because we are on skin, this is what we're talking about. We want to teach clients or people to stay covered outdoors, all right, to expose as little skin as possible, especially fair-skinned individuals. Stay covered outdoors, use sunscreen, and remember it needs to be an SPF of 15 or higher. They're to always use sunscreen, not wait out there. That, if they're going to be going outside, go ahead and apply this sunscreen. Avoid exposure between 11 a.m. and 3 p.m. And then to inspect for lesions once a month and report any changes, any mole or a lesion, to the doctor. All right, that's it. That's a quick little recap of Unit 3. And just go ahead and study the 3 recaps that I have, and hopefully you'll find them helpful to you. Thank you.